Whatever is true, whatever is noble, whatever is right, whatever is pure, whatever is lovely, whatever is admirable, if anything is excellent or praiseworthy, think about such things. Philippians 4:8. And today we're going to start with membranous nephropathy. The most common cause of nephrotic syndrome in white people is membranous nephropathy. It's caused by antibodies against phospholipase A2 receptor. You see a spike in dome appearance on electron microscopy. Immunofluorescence shows a diffuse granular pattern of IgG along capillary loops. You're going to see a thickened glomerular basement membrane. You're going to see fenestrated endothelium. You're going to see subepithelial immune deposits and podocyte with the faced foot processes. So let's see what Melman said about this. So, membranous nephropathy. The answer on USMLE for nephrotic syndrome in a patient who has um, exposure to drugs like dapsone, gold salt, sulfonamides, or infection like hepatitis B, Hep C can cause it too, but rare. Visceral cancer like breast and pancreatic. And autoimmune disorders. Autoimmune primary antibodies against phospholipase A2 receptor. The light microscope image is important and shows highly eosinophilic pink and inflamed thickened capillary walls. This is the thing. This is the photo for membranous nephropathy. You see a spike in dome appearance of subepithelial deposits of electron microscopy. So, an autoimmune primary antibodies against phospholipase A2 receptor. So, in the first date, it says focal segmental glomerulonephritis. No, wrong one. Membranous nephropathy, also known as membranous glomerulonephritis, can be primary, which has antibodies to phospholipase A2 receptor, or secondary to drugs. So, basically, somebody can get membranous nephropathy. So, when it says can be primary, that means that the body makes antibodies directly against the phospholipase A2 receptor, and that means you have membranous nephropathy. And secondary membranous nephropathy is membranous nephropathy caused by another disease, like another autoimmune disease like lupus or NSAIDs or penicillamine or gold, or some infections like hepatitis B or C or syphilis. Okay, so anything that happens because it's primary is that just means that you have a kidney specific autoimmune disease that makes antibodies against phospholipase A2 receptor. If you have something else, like if you have a membranous nephropathy due to some other issue that's known as secondary, that's known as membranous nephropathy due to a secondary cause like NSAIDs, penicillamine, or gold, or hepatitis B or C. Okay, and membranous nephropathy can be seen in somebody with solid tumors. Primary disease has poor response to steroids, may progress to chronic kidney disease. On LM, you see diffuse capillary and GBM thickening, like we just saw. Like light microscopy, you will see very thick GBM. See? This GBM is not supposed to be this thick. So, yeah. And IF, you'll see granular due to immune complex. On immunofluorescence, it will be granular due to IC deposition, due to immune complex deposition. So, primary membranous nephropathy is caused by anti-PLA2R IgG antibody forming subepithelial immune complex complexes on podocytes, activating complement and causing proteinuria. Okay, so the antibodies in membranous nephropathy causes um, complement to get activated, and this causes proteinuria. That's why it says immune complex deposition right here. So the spike and domes you see on membranous nephropathy, LMIM, EM. So spike and dome appearance is what you see in electron microscopy, and that I'll show you a photo of it. That is actually immune complexes. Okay, let's see. See, membranous nephropathy, spike and dome appearance. So, okay, it's this. It's like around the glomerulus. See this? This dome? That's what it is. So this entire thing is the glomerulus, and it's in the glomerulus, but all around inside the glomerulus. See this? So here it would be these domes. So the spike and dome appearance would be happening inside the glomerulus, specifically along the outer side of the glomerular base membrane. That's why it's subepithelial. So subepithelial means below the epithelium, and that'll be between the GBM and the podocytes. They like to ask the location. That's what it is. So see this. This entire thing is happening inside the glomerulus. Um, it's happening along the outer side of the glomerular basement membrane. Okay, so right here, this is the GBM right here, this black lining, and the spike and dome appearance is above the black line, which is the basement membrane of the glomerulus. And exactly, it would be between the GBM and the podocytes. Spike and dome appearance, which are IC deposits, are between the GBM and the podocytes, and they are subepithelial. Remember, subepithelial in membranous nephropathy. They might ask you to identify where it is, and it's right here. So here it would be subepithelial. So below the basement membrane. I can't tell you all how stressed I am about this exam, but this is gonna be me venting randomly. contemplating about my life, but you gotta do what you gotta do. So, next we have immunofluorescence patterns in the glomerulus, linear appearance, anti-glomerular base membrane disease, and we have granular appearance, immune complex deposition diseases, like post-streptococcal glomerulonephritis and membranous nephropathy. They are both immune complex deposition diseases, but linear appearance, that would be good pasture syndrome. So in good pasture syndrome, you have even membrane deposition of antibodies throughout the glomerulus, and it just looks like a green light bulb, and it's very green, and those are all antibodies. In a granular appearance, such as post-streptococcal glomerulonephritis and membranous nephropathy, though it looks patchy. It looks like some areas of the glomerulus are black, some areas are green. The green areas are immune complex deposition. And where are the immune complex depositions? They're between the GBM and the podocyte. Specifically in the subepithelial space of GBM, which means below the GBM and between the podocyte. Like between the GBM, so that'll be between the, like below the epithelial lining of the GBM and the podocyte. The epithelial lining, yeah, between the epithelial lining of the GBM and the podocyte. Okay, next. Focal segmental glomerulonephritis. Here you're going to see segmental sclerosis. Yeah, you're going to see segmental sclerosis, which means parts of the glomerulus will be sclerosed. Focal segmental sclerosis. This is the most common cause of nephrotic syndrome in African Americans and Hispanics. Can be primary and idiopathic, so without a disease and without a cause, or secondary to other conditions like HIV infection, or sickle cell, or heroin, massive obesity, interferon treatment, or congenital malformations. Primary disease has inconsistent response to steroids, and this can progress to chronic kidney disease. LM, you will see segmental sclerosis and hyalinosis. So LM, let's go look at it. LMB. So you see this right here. You see this. Most of it looks like a regular nephron. I mean regular glomerulus. This right here, you see hardened area. This is focal segmental glomerulonephritis. Did I say nephritis? Focal segmental glomerulosclerosis. Okay. So on immunofluorescence, it's often negative, but may be positive for non-specific focal deposits of IgM, C3, and C1. Okay. Often negative, but may be positive for non-specific focal deposits I don't know what happened to my English. Somewhere along the way, it's become something else. Deposits, deposits of IgM, C3 and C1. Okay. IF often negative, but or may be positive for non-specific focal deposits of IgM, C3 and C1. EM, effacement of food processes similar to minimal change disease. Okay. Let's see what Melmu had to go say about this. So, focal segmental glomerulosclerosis, the answer on U.S. Assembly for nephrotic syndrome and sickle cell, heroin, or HIV, not as responsive to steroids as minimal change disease. FSGS literally means some parts of the nephrons are affected. Focal, some glomeruli, diffuse, all glomeruli, segmental part of nephron, global, all of nephron. So somebody has HIV and they have proteinuria. The answer is focal segmental glomerulosclerosis. Okay. Next, we are going to talk about minimal change disease. Minimal change disease is when you have foot process effacement and fusion. There's a lack of immune deposits in basement membrane. There's a lack of immune deposit. There's a lack of immune deposits, and you have basement membrane thickening. Okay, so here, minimal change disease is this, also known as lipionephrosis, most common cause of nephrotic syndrome in kids, often primary and may be triggered by recent infection, immunization, immune stimulus. Uh, Rarely may be secondary to lymphoma, like cytokine mediated damage. Primary disease has excellent response to corticosteroids. Primary disease has excellent response to corticosteroid. Elum, you see normal glomeruli, lipid may be seen in PCT cells. Elum, normal glomeruli, lipid may be seen in PCT cells. So, like microscopy, you see normal glomeruli. On immunofluorescence, you see nothing. On EM, which is like the black one, the black microscope, you see effacement of photocyte foot processes. Okay, you see that? They all look smushed together. The podocytes look smushed together. And they all look like they're fused together. That's minimal change disease. Okay. So, minimal change disease, the answer on U assembly for otherwise unexplained edema in a kid who doesn't have blood in the urine presents as peripheral edema, periorbital edema, and or ascites. Almost always, this is pediatric. Very rarely, it can be due to Hodgkin in an adult. A classically post-viral, as in upper respiratory tract infection. But 50% of vignettes won't mention that. In other words, textbook vignette is an 8-year-old girl who has sniffles for 4 days, followed by peripheral and periorbital edema a week later without blood in the urine. Once again, though, the stem need not mention the viral infection called um, called minimal change disease because light microscopy shows no abnormalities. EM, however, shows effacement of the podocytes. Minimal change disease is it looks like lipid droplets can be seen in urine or LM. Mechanism for nephrotic syndrome is loss of size in charge barrier. Corticosteroids are the treatment and are highly effective. A 2CK PEDS question gives minimal change disease as etiology for spontaneous bacterial peritonitis. Any cause of ascites can cause. What is this SB? Any cause of ascites can cause SBP. I discussed this stuff in the GAT PDF. Okay. Oh. Any cause of ascites can cause spontaneous bacterial peritonitis. Okay. Minimal change disease. I feel like I can answer most questions about renal. Most. Minimal change disease. Okay. Important nephrotic symptoms for USMLE. Membranous glomerulonephritis nephropathy, minimal change disease, focal segmental FSGS. Renal amyloidosis. Okay. What was focal segmental glomerulosclerosis? The part where there's sclerosis. There's a part where there's this one. It's hardened in the nephron. This is the one you see in black people. So this is the one you see in black people, and if somebody has HIV, sickle cell, heroin, the answer is focal segmental glomerulosclerosis, and in membranous nephropathy, it's someone is on NSAIDs, penicillamine, gold, or hepatitis B or C, syphilis, lupus, or the cancer, solid cancer. Then they have membranous nephropathy. What is membranous nephropathy? Nephropathy, someone where you see spike in dome. Okay. Next, we are talking about hairy cell leukemia. Hairy cell leukemia, you see hairy cytoplasmic projections. Here, there's fibrosis in the bone marrow that causes bone marrow failure, causing pancytopenia. Bone marrow aspirate cannot be aspirated, so you see dry tap. You see this is a B cell tumor. It is trap positive. You will see lymphocytes with cytoplasmic projections. We're gonna look this up now. So this is what Melman has to say about hairy cell. This is what they look like. Okay. So, well, hold on. Hairy cell leukemia. Q. So the question will say the patient has leukemia, characterized by cytoplasmic projections as stain positive for TART, resistant acid phosphatase, which is TRAP. Continue down. This is what they look like. These cytoplasmic projections coming out of T cells. See, it says adult. It is not a T cell. It is a B cell. It's a B cell. Oh, great. Hairy cell leukemia. So, my entire life I thought hairy cell leukemia was a T cell tumor. It is not, it's a B cell tumor. Adult males, mature B cell tumor cells have filamentous hair like projections, fuzzy appearing on elm. Um, Peripheral lymphadenopathy is uncommon, causes myelofibrosis. You see dry tap on aspiration. Patients usually present with massive splenomegaly and pancytopenia. Stains trap positive. Trap stain largely replaced with flow cytometry associated with BRAF mutations. Treatment is cladribine pentostatin. Okay, so that's that. Hey monk. Um, the stem can give low WBCs, which is unusual for leukemia. 9 out of 10 questions for leukemia will give ultra high yield to WBCs. 9 out of 10 questions for leukemia will give ultra high yield to WBCs. The MBB questions of xenohairy cell leukemia gives image similar to the above and gives 3500 and gives WBCs 3500, and they say WC WBCs with cytoplasmic projections and states positive for TRAP. What? The stem can give low WBCs, which is unusual for leukemia. Right, it should be high. 9 out of 10 questions for leukemia will give ultra high yield. Does it say high yield? High. Hold on. Let's see what the. Um. Okay, so what he's trying to say is that 9 out of 10 questions for leukemia will give ultra high yield to WBCs. The MBB question of senile hairy cell leukemia gives similar image to above, gives WBCs 3500, which is low, and they say WBCs have cytoplasmic projections and states positive for TRAP. So he's trying to say MBB, how they ask this type of question is that they give low WBCs, which is unusual for leukemia. However, in hairy cell leukemia, it is the low WBCs, and you have the cytoplasmic projections, and you have TRAP positive. Okay, next. Okay, 9-year-old female with a WBC of 3500 smear shows WBCs with cytoplasmic projections that stain positive for acid resistant acid phosphatase. The answer is hairy cell leukemia can have low WBC count. Next. Okay, we covered it. Yeah, we're done. Next question. Okay. So you had to know that there's fibrosis in the bone marrow that causes bone marrow bone marrow failure, causing pancytopenia. The bone marrow aspirate cannot be aspirated, so you have dry tap here. This is a B cell tumor. Um, hairy cell leukemia is a B cell tumor, not a T cell. Okay, good. Next, we have functional hypothalamic amenorrhea. This is the one that you get, like, for example, okay, this is the one that all the anorexic girls get. That you have extremely low body weight. You go to the gym, you know, 7 times out of the week, train for 2-3 hours a day. They lose their menstrual cycle and they have bone loss. Actually, what happens is that there's excessive weight loss, the strenuous exercise, you have chronic illness, and this is a eating disorder. You have decreased adipose tissue and fat reserves. You have decreased leptin production, and this will cause decreased GnRH release from the hypothalamus, and that will cause decreased LH and FSH release from the pituitary, and that will cause decreased estrogen release from the ovaries, and that will cause amenorrhea and bone loss. Okay, so it's known as functional hypothalamic amenorrhea. These patients have decreased leptin. What does leptin do? Remember, ghrelin is what tells you when you're hungry. So leptin must be it tells you when you're full. Leptin acting as a satiety signal from fat cells to the brain to suppress appetite, increase metabolism, and reduce food intake when fat stores are high. By low levels trigger hunger and energy. Okay, so the next we have more biliform drug eruption. Um, this is the rash. It's a type 4 hypersensitivity reaction that starts on the trunk and spreads to the arms and legs. Carbamazepine and phenytoin, TMP, SMX, and antiretroviral therapy can cause this rash. There is no mucosal involvement, unlike Stevens-Jones syndrome. So this more biliform drug eruption is caused by carbamazepine, phenytoin, TMP-SMX, and it's a diffuse non-tender erythematous macules, papules, mesos-like involving the trunk rash. It's a type 4 hypersensitivity. Okay, it starts on your stomach and spreads to the arms and legs. So basically, more biliform drug rash is a centrifugal rash that starts on the trunk and spreads to the arms and legs. That would be a centrifugal rash. A Rocky Mountain spotted fever rash is a centripetal rash that starts on the wrists and ankles and spreads to the trunk. So a rash that starts on your stomach and then spreads out to your arms and legs, that would be a centrifugal rash. And a rash that starts on your wrists and ankles and spreads to the stomach, that is known as a centripetal rash. And a centripetal rash is what's seen in Rocky Mountain spotted fever, and a centrifugal rash is what's seen in more biliform rash. Okay, next. A patient with SLE has sudden MI. She had mild hyperglycemia and increased BP and osteonecrosis of the femoral head 1 year ago. Her adrenals would show what? Bilateral cortical atrophy. That is the answer. We're supposed to know glucocorticoids she took for SLE would suppress the hypothalamus. Suddenly stopping exogenous corticosteroids will cause adrenal crisis. Chronic glucocorticoids use can cause osteonecrosis, and both Cushing syndrome and SLE can increase the risk for coronary events. We'll go through that. So, what are features of Cushing syndrome? Dorsal cervical fat pad, bruising, central obesity, which is like a pot belly, and then supraclavicular fat pads, moon face, muscle wasting, striae. This is classic features of Cushing syndrome. Yeah, so the question describes a patient with SLE, has a sudden MI. She had mild hyperglycemia, an increased BP, and osteonecrosis, a femoral head 1 year ago, because that's common in Cushing's, right? Femoral head, like the femoral head osteonecrosis. Mm, or was it avascular? It was avascular necrosis of the femoral head. That's common in uh, Cushing's. I think it's common in Cushing's. But here it's talking about osteonecrosis of the femoral head. Okay. Her adrenals would show what? The answer is bilateral cortical atrophy. We're supposed to know glucocorticoids she took for SLE will suppress the hypothalamus, and then if you suddenly stop exogenous corticosteroids, that will cause adrenal crisis. Chronic glucocorticoids use can cause osteonecrosis, and both Cushing syndrome and SLE can increase risk for acute coronary event. So chronic glucocorticoids use can cause osteonecrosis and both Cushing syndrome and SLE increase risk for coronary event. Okay. So the takeaway point is that suddenly stopping glucocorticoids will cause bilateral cortical atrophy of the kidneys. Next, SVT is most common pediatric arrhythmia. A rapid heart rate causes ventricular diastole to shorten and decrease stroke volume, and cardiac output causes hypotension. Infants develop lethargy and tachypnea, crackles, and hepatomegaly. Okay, SVT in is most common pediatric arrhythmia. Supraventricular tachycardia is the most common pediatric arrhythmia. Rapid heart rate causes ventricular diastole to shorten and decrease stroke volume, and cardiac output causes hypotension. So if you rapidly have like a high heart rate, this causes ventricular diastole to shorten. Ventricular diastole is like like when your ventricles fill with blood. Yeah, if you're rapidly pumping your heart, the ventricle cannot fill with blood during the filling time, which is diastole. That will cause decreased stroke volume and decreased cardiac output, and that will cause hypotension. Because if you're not allowing the ventricles to fill with blood because your heart rate is way too high and your heart is beating out of whack, that means you don't have enough blood in the ventricles to pump out. So you have a decreased stroke volume and a decreased cardiac output, and this will cause hypotension. Infants develop lethargy, tachypnea, crackles, and hepatomegaly in supraventricular tachycardia. The rate is usually over 150. Heart rate is usually over 150 in adults, and for babies it would be over 220. That's when you know you have SVT. The P wave is not visible. It's buried in the QRS or T wave, and then you see a lot of QRS complexes that are shortened.